Thank you everyone for having me. Hopefully I can give you a bit of an idea of what interventional radiology and musculoskeletal interventional radiology is all about. So by way of introducing myself, my name's Amit Lakkaraju, also known as Amit. And what I am is I started off as an orthopedic trainee and then very quickly saw the ceiling there and went into radiology and specifically musculoskeletal radiology. That was 2004, something like that. And so musculoskeletal radiology, after completing a couple of fellowships in the UK, in Leeds and Liverpool, I came over here and landed up in lovely Shepperton. Does anybody know Shepperton? Shep was where I broke my teeth, basically, in MSK. It was a great place, great to bring up the kids, great to do a large cohort of patients, and great to introduce things that weren't available in regional and rural Australia. So that's where I've sort of learnt my craft as such. So MSK intervention is where what I sort of mainly love doing, and venous intervention is my other side of things. So varicose veins, venous ulcers, spider veins, and surprisingly, those two cohorts have a lot of overlapping issues. So you have patients who've got venous varicose veins who are flat-footed, who have got osteoarthritis of the knee and therefore can't mobilize. One of the things that we need to do with venous issues is to mobilize them, because if they don't mobilize, then their calf pump doesn't work. If their calf pump doesn't work, then they have stagnation. And then from that comes a whole bunch of issues, one of which is DVT, the other one is ulceration, edema and lymphedema, and then the third one is, surprise, surprise, peripheral neuropathy. Okay, so that cohort has a huge musculoskeletal component, and same thing happens in musculoskeletal issues. So lower limb musculoskeletal issues, a lot of you would have noticed that they've all got venous issues too, you know, whether it's spider veins, large varicose veins, venous ulcers, or they've got lymphedema. So that's where most of my work at this point in time is. So I'm primarily a procedural radiologist. I also do a lot of diagnostic work, mainly musculoskeletal ultrasound, but I was doing a lot of MRI before this. So I thought because we're within a group of predominantly podiatrists, I thought I'd sort of base a lot of my work on podiatry type issues, lower limb issues, but also talk a lot about image-guided interventions. So obviously we've got all of these going on. Ultrasound, MRI are probably the main things that I use a lot of. CT less so, because it does give you bony morphology, but isn't as useful as a combined soft tissue and bony morphology which MRI does. Fluoroscopy is really good for guiding treatments, but you know, truly to the real sort of leaps and bounds of musculoskeletal work has come in ultrasound and MRI at the moment. So what are we doing? We're going to talk a little about ligament injuries, Achilles tendonitis, plantar fasciitis and fibromas. So with regards to ligament injuries, I'm just going to quickly go through a lot of this sort of stuff. Obviously conservative and surgical methods are there. With ultrasound we can work out which ligaments are involved, whether there's a sinus tarsi syndrome, and then that MRI comes into it when you're looking for osteochondral lesions. So our major modalities for imaging are X-ray and ultrasound. So with X-ray we get a number of views, and you know, you get a bit of an idea of whether there's any widening, whether there's any fractures. So the standard view is at the AP or mortise view, and they're static images, whereas ultrasound is very dynamic too. It gives you exceptional soft tissue visualization, and also can be combined really well at point of care with your physical examination, and can be used. I liken ultrasound to your magnifying glass. You look at a spot, you think, okay, there's something going on, and you can use that magnifying glass to really assess it and investigate it. The thing about ultrasound now is that it's a multi-prismed magnifying glass. So there are multiple modalities within ultrasound that you can use, that hopefully I can show you, to assess these. So this is standard B mode. For those who are unfamiliar with ultrasound, this is the ligament. It's got a fibrillation, which is really nice. This is the fibula, this is the talus, so this is the ATFL. The CFL on ultrasound is between the fibula and calcaneus, and you can see it really nicely. And then this is a normal ATFL. Thank you, James. You can see it nicely becoming taut as you dynamically assess it. There it goes again. MRI is really great for static soft tissue and bony assessment. So you can really see collagen heavy structures as really dark areas. So collagen heavy tendon here. Show you collagen heavy Achilles tendon. You got your Tom, Dick and Harry. You got your peroneus longus and brevis, and you've got your ATFL. So that's the talus, that's the fibula. And so that's what we call the axial plane. This is the coronal plane. And MRI, it's primarily static images. You can, to a certain extent, use dynamic videos. That's coming into the fore with MRI a little bit more, but it's really intense. How many of you have been in an MRI machine? And how long did it take? Yeah, a fair while. So at a minimum, an MRI takes about 30 minutes. Maximum, it could take up to 2 hours. So, if you're doing multi-region assessments, they can be really long, and for a lot of patients, it can be really difficult. The other thing that a lot of people don't tell you about is how much energy that deposits in your body. Because the reason why you get the MR image is because radio frequency energy is actually imparted to your body to then change hydrogen molecules and the protons in the hydrogen molecules. So it actually changes the magnetic field, and from that, as energy is released from those elements, you then get a map. So that MRI image is actually a map of the magnetic fields within your body. Okay, so a lot of people who have chronic pain will often find that it's very difficult to go into a magnet because they find that it actually can stir up their pain. If you ask a lot of people who have, say, things like fibromyalgia or chronic headaches, or a facial pain, they really don't like going in them. So MRIs can be really effective in checking out fluid. So we do a specific sequence called a fat suppressed sequence. So there may be proton dense or just T2 weighted sequences. Essentially what it's showing up is it's subtracting a lot of the bony architecture and showing up fluid. So here you've got a nice little image of a fluid within the posterior calcaneal joint. You can see this sort of edema. So those are they're the lymphatics that you can see in there. This is lymphatic fluid around the extensor hallucis longus tendon, sinus tarsi. You can see the sinus tarsi ligaments quite nicely. And then, yeah, get a bit of an idea. I'm going to skip through a lot of this sort of stuff because I don't think it's that useful. But what is useful is going back to what pathology looks like in those sort of situations. And this is another image that James has kindly shown me. And you can see how stiff that joint is. So you can see how it's pretty well fibrillated in this section of the ATFL, but over here you can see how it's disorganized, and that little area there is a little bony spur that's come off. So a lot of the time what we see on ultrasound is irregularity of the cortex. So that irregularity of the cortex, if you take it down to the microscopic level, you'll find that there's some periosteal elevation. So periosteal elevation, obviously the periosteum contains osteoblasts. So when the periosteum is elevated, it produces a fracture-like reaction for those osteoblasts to form bone. And so bone spurs are basically an osteoblastic reaction. Same thing occurs in an inflammatory setting, which is osteoarthritis. And that's why you get those bony spurs forming within the ligaments. It's because there is a inflammatory trigger that then allows osteoblasts to form within the ligamentous structures. Same thing occurs in the setting of instability. So although bone spurs are very common, the actual cause of bone spurs is either an inflammatory or traumatic or an instability trigger. Okay. So that's what ultrasound's really grateful for. So if we look at the Achilles tendon, you can really see it nicely. You can see both the deep and superficial structures. You can see vascularity. You can see the retrocalcaneal bursa. You can see Haglund's morphology. So this is a standard B mode image of the Achilles tendon. So let me give you a bit of an idea. Skin, subcutaneous retro Achilles fat. You've got the Achilles tendon there in a very striated, smooth appearance. You've got the Kagar's fat pad there also, quite nicely seen. And then even deeper to that, you've got the soleus, and then deep to that, you've got the posterior aspect of the tibia. So that's a normal Achilles tendon. So take note of the paratenon there. And this is an abnormal Achilles tendon. So essentially, although it's not well projected there, so that's the fat there. You can see how heterogeneous it is compared to this image. You can see that striation that you can see in the normal one is absent there. And you can see how it is specifically around the dorsum there, okay? Because of ongoing mucoid degeneration in the Achilles tendon, it allows easier through transmission of sound waves. So that's why the fat here is a lot more brighter. Okay, so remember the Achilles tendinosis is it causes that reduction in stiffness of structures. Okay, and as a result, you get more through transmission going on. This is a really nice image of the insertion site. So you've got the Achilles tendon going in and inserting onto the calcaneus. Depending on how nerdy you are, you can find out how low the insertion can be. And that also has direct effects on biomechanics. It also has direct implications for how much impingement is occurring there. Okay, and then you've got this little teardrop structure, which is basically fluid within the retrocalcaneal bursa. And you can also see the morphology of the calcaneus too. So, you know, from a morphological point of view, it's really effective. Dynamically, you can actually see everything going on. And then more and more we're now using microvascular imaging. So as you can see, this is a little image of vessels deep to the Achilles tendon in that area. Now, this is where ultrasound is going on, and these are those prisms that we talked about. So more and more we're using microvascular imaging to assess where those vessels are. So yes, there's microvascular entry or neovascularization within tendons, but what does that really mean? Yes, it means that there's a loading phenomenon going on. But in actual fact, what it also allows us to do is to identify some of the pain generators, because all of those little vessels, where they enter into the Achilles tendon, there's also, they're all neurovascular bundles. So they are in themselves pain generators. So the recent trend of paratenon stripping, well, it is much more effective to strip the deeper paratenon than the superficial paratenon. Although it's nicer to strip the superficial paratenon, the deeper paratenon is where a lot of those vessels are coming in, where all those nerves are coming in. And then we come to the concept of connective tissue and fascial adhesions. So deep down here, we've got a lot of adhesions that are occurring between Kagar's fat pad and the paratenon. So by stripping them, you actually allow a lot more of the movement. Okay. Another thing that's come out, which a lot of people may or may not have heard, is elastography. So elastography is a technique within ultrasound to look at stiffness of tissues. We know that tendons are not very tendinopathic tendons have got areas of fissuring, of mucoid degeneration. But what the elastography does is it defines those in a much more effective manner. So in this case, you've got a tendinopathic tendon, you've got a red area there, which is basically a map of how stiff that tissue is. So this red is a lot more stiffer. As you go in, you can see this little area that's going through, which is deep blue. That's a cleft within the Achilles tendon. So you can't really see that cleft so well on B-mode imaging, okay? Again, as you go down, you can see the red tissue. That's the soleus, okay? And you can see the areas of bluish tinged tissue. That's Kagar's fat pad. So to a certain extent, within the tendon, you can identify where all of these things are. So that also can be helpful with regards to not only targeting sites for doing intervention, but also for pre and post therapy assessment. Another one that's really cool is something called B-Flow, which I've been playing with a fair bit. So B-Flow I use within for really, really slow flow venous issues. So this is the vessel that we're looking at, and this is the flow within that vessel. So that is a feeder for spider veins on the surface of the skin. So you can see this flow is basically much more slower flow than you would be able to insonate using standard Doppler ultrasound. So that can be really helpful in venous malformations, but it can also help in guiding your needle when, for example, you're trying to ablate those areas of neovascularization, okay? So Achilles tendon stripping, we know they've gone through a course of rehab and shockwave therapy. Some people use steroids. I'm sort of moving further and further away from using steroids and more towards prolotherapy, primarily because there's nothing wrong in using steroids to reduce inflammation. But the systemic effects of using multiple courses of steroids is something that I'm a bit worried about. We have a huge population of people, certainly in the older age group, who have got really low bone density. Using this reduces their bone density. Reducing steroids can reduce their bone density when you do multiple courses. The second thing that it does is it causes laxity and breakdown of collagen a lot more. So the more cortisone you use, the more likely you are to make the soft tissues a lot more softer. And to a certain extent, there is an inflammatory component, but chronic inflammation is not just, is not completely suppressed by steroids. And the other thing that it can do is it can cause a lot of issues with the your cortisol levels. So it has implications on metabolic health too. So steroids have their place, don't get me wrong. About 10% of my work now is steroid work. The vast majority, 90%, is non-steroidal work, okay? So for Achilles tendon stripping, it can have its place, but I urge you to use really small amounts. Dexamethasone is probably a better steroid than any others. It's a much more short-acting steroid because it's a purer one, but you don't get the secondary effects of particulate steroids. So particulate steroids, things like Celestone, Kenacort, have got varying sizes of particles which are formed by additives to them. And so one of the issues that can happen is they can crystallize, and they can actually give this abnormal worsening of pain. I saw this lady who had a shot of dexamethasone in her coccyx. Great result, was great. Then had a shot of Kenacort in her coccyx and has gone down this huge rabbit hole for the last 12 months of PTSD, severe coccygeal pain. I don't know if you've ever come across people who've got pelvic pain. It is horrible. And so, this lady is in a heap of pain. So certainly be very careful about particulate steroids, and certainly be very careful about Kenacort. Ultrasound for tears is really effective. And that's where elastography can come in also, so you can see where the tear is a little bit more clearly sometimes. This is an interesting one, although this is the biceps. This is where elastography was used for looking at a scar. So this is a scar tissue, and this is the scar tissue. So you can see where the fascia is and the scar tissue is. The red is where the scar tissue has been the most thickest and dense. So over here we've got a lot of red going on, a lot of red down here. We did prolotherapy, and you can see how that scar tissue has broken down. So what's changed from stiff tissue has become a lot less stiffer. So elastography can be useful to prove that you've broken down tissues a lot more. Is it a huge extra addition to your stuff? No, not really. I mean, you know that when you're breaking up scar tissue, you can feel how the tissue changes, whether you're using shockwave, whether you're using manipulative therapy, whether you're using other things. But from an ultrasound point of view, you get a much more effective idea of how that scar tissue changes, so that you then have an objective measure. Now, this is what's called shear elastography, but strain elastography actually gives you objective measures of this too. So you can actually record how the stiffness is changing in time, which is really, really quite exciting. Achilles enthesopathy is one of those issues that is very common. We've got areas of calcification that you can see. Shockwave's great for that. I love it. Dry needling under ultrasound can be really effective. If you use PRP also, you can do a great job, because the macrophages will go in and then eat all this tissue up too. Ultrasound's great for Achilles retrocalcaneal bursitis, because you can check for where everything's going on. And then Mark will talk to you a lot about Haglund's and how X-rays are great for Haglund's deformities. Ultrasound can be really effective also for actually seeing the impingement occurring. So you can take some objective measures, but on ultrasound you can actually see these tissues, how the Achilles tendon is thickened. You can see these clefts forming where the insertion site is, and you can actually see the Haglund's deformity on ultrasound too. So I'm a big fan of ultrasound. Again, this is microvascular imaging to see where the areas of Achilles tendinosis are, and can be used for trying to work out where to do your intervention. So we use sclerotherapy for these areas. So we actually, under ultrasound guidance, pass sclerosant into these and then close them off. So I'm going to run through here. Okay, so this was an interesting case. A more and more an area of interest that I've started seeing, certainly on MRI, is how you can get impingement between the plantaris and the Achilles tendon. So this was one patient who had fusiform Achilles tendon. On MRI, you can see a lot of edema, lots of edema. Here's the plantaris on the medial aspect. And then this is the plantaris there. And as we go down, that's the site of maximum impingement. That's where he was point tender. That's where most of the inflammatory change was. And then you can see the plantaris tendon coming off there. So more and more fusiform Achilles tendinosis, we are seeing this. Whether it's a huge cause of fusiform mid-portion Achilles tendinosis or not is still to be worked out. But interventions can be really useful in this. So here's the ultrasound again of that same gent. And that is the, that's the plantaris there. You can see where it's impinging. You can see the hypervascularity there. And as it goes on, you can see it changing. So what can you do from an interventional point? Well, you can actually hydrodissect this plantaris tendon out, or under ultrasound you can actually do a tenotomy of these tendons. So more and more I'm using specific needles to actually release up these tendons, and they can be really effective in helping out with that side of things. So plantaris fiction syndrome, as I said, is a very underdiagnosed area. Image-guided interventions here. So what do we do? Well, I use primarily ultrasound now to do a lot of my treatments. I don't have the luxury of CT. I don't have a C-arm. But really, in my practice, I find that for most things, about 99% of all my treatments I can use ultrasound for. So that's the power of ultrasound now. It is a very, very effective imaging modality, much more so than other modalities, without the issues of radiation. Okay. So what substances do I use? Obviously steroids, dextrose prolotherapy, PRP, less so alcohol. We can use needles for fasciotomies and tenotomies, radiofrequency lesioning, and more we're using cryoablation. So we talked a little about steroids, so I'm going to move on. So ultrasound's really effective for actually seeing the needle go in there and dump your stuff. Prolotherapy is quite an interesting substance. I hadn't come across prolotherapy for quite some time. You guys in the podiatry space have been using it for a long time. But prolotherapy started off primarily for stiffening up ligaments, and also for reducing neuropathic pain on the surface of the skin. So for me, I use mainly 5% dextrose, but also for nerve hydrodissections, and then 10 to 15% dextrose for skin thickening. And it's a really good regenerative substance. It's about 1/3 as powerful as PRP. And it has obvious regenerative actions. It is pro-inflammatory. It does activate myofibroblast mesenchymal stem cells and does also help in modulating the TGF-beta. It has a sclerosant factor. When we use prolotherapy, I'm primarily trying to release up tissues in my practice because I'm so much nerve focused. So 5% dextrose has been really good. We can actually image these tissues really nicely and then check them out and then see them getting released up. So you can use them under a number of areas. So as I said, sural, saphenous, Achilles, ankle hypermobility areas. PRP, a lot of us know a lot about PRP. It's basically a centrifuged product. We take blood out and then we inject it back. The science behind PRP is hugely increased. So we are now looking into the byproducts of PRP, things like platelet lysate, which is a breakdown product of PRP, how we can change the PRP to be more pro-inflammatory or less inflammatory by changing the amount of leukocytes within it, changing the amount of monocytes, and it's all to do with how you spin the product and what kits you use. And if you're really, really nerdy, you can go and then get yourself a little lab, have the lab tech do all of those sort of things. We're into that space of interest with PRP. Platelet-rich plasma is the base regenerative substance. Mesenchymal stem cells, or medicinal signaling cells as they're called, are the next generation. And then the next generation from that is autologous and allogeneic expanded cells. So there are centers that do all of that, one of which is over here. So PRP is obviously a pro-inflammatory substance. It releases a lot of cytokines, recruits stem cells. It is antiseptic. Interestingly, I had a patient who had discitis, and we were able to reverse the discitis with PRP when we were doing it. Dose is a huge factor. Gone are the days where we'd take piddly 10 mils of blood. That doesn't do anything. We need to get larger volumes, and the way you do that is taking larger amounts of blood. 60 plus mils. For my spinal cases, I can take anywhere between 120 to 240 mils of blood. Okay, and then we also test dose the PRP, so we're looking at over 8 billion platelets. If we're going to get a good result, clinically proven result, then we need to get above 8 billion platelets. And the only way you're going to get that is high dose, high volumes, okay? In our clinic down in Geelong, we have a hematology analyzer, so we actually check the doses of our platelets, and we know how much we're doing. So you can combine PRP with hyaluronic acid. You can combine PRP with 5% dextrose. You can combine PRP with radiofrequency, pulsed radiofrequency. So essentially, they're all techniques that can be combined together. So how I think about regeneratives is this, the sun and soil theory, okay? It's a really corny thing to say, but basically, in most musculoskeletal conditions, you have an area that is degenerate, i.e. poor soil, okay? So what you got to do is you got to fertilize that soil, get the nutrients back, and then get that sun shining on it and get the seeds into it, okay? So the sun is your photobiomodulation, so your laser, okay? The energy devices are exceptionally helpful in regeneratives. Whether you do it pre or post or use both, I can't tell you how much it's changed my practice. Okay, photobiomodulation is one of the most effective treatments around there. Same thing with shockwave therapy too. That energy entry is exceptionally important in helping improve the energy, putting energy back into a system that's depleted. So the sun is your energy source. Then what you need to remember is that you need to put fertilizer into that soil. And that's what PRP does, okay? Your PRP is your fertilizer. And there's a dose limit to that. You know, a minimum dose of between 5 to 10 billion platelets will start an inflammatory reaction. We know that low-dose PRP doesn't work. It's been shown multiple times in RCTs. Even RCTs done here in Australia have shown that you can't really produce a good result with a low-dose PRP. That's why you need higher doses, and that means higher collection volumes. Okay, so the PRP is your fertilizer, and then the stem cells are your seeds. Yeah, so there's a paucity of those stem cells, or they're not being activated. So PRP can activate it, but stem cells will. You can actually harvest those stem cells and put those in. So at our Geelong site, we do a lot of lipoaspirates for knee osteoarthritis. We do bone marrow aspirates for hip and lower back issues, but we also use a lot of PRP. So the philosophy of regeneratives is this: you have to have metabolic optimization. So how do you do that? A good panel, including HbA1c, your B6, B12 levels, your iron levels, all of those become important. I give all my patients an IV therapy with a mix of various substances to try and then optimize it so that we get the best marrow secretion of platelets. A lot of our patients are dehydrated or poor metabolized. And then we do a multimodality targeted approach. So as you know, there's never one target that's causing all the issues. So you might as well target multiple areas. So for example, in the Achilles, we do sclerotherapy to those microvessels in addition to targeting the PRP. We also do injections into the ankle joint at the same time with PRP, and we hydrodissect, okay? And then we do a structured rehab and energy medicine protocol, whether you're doing shockwave, magnetotherapy, or photobiomodulation. For me, photobiomodulation has been the way I've gone about it. And using this methodology, my results, I now have probably a 5 to 10% failure rate. Okay, so flip side of that, 85 to 90% of all my patients who go through this come out the other end feeling at least 80% improved in pain and function. And that equates to 12 months plus. Okay, so that's the regenerative strategy. It's not just a point and shoot situation. So we do it for a lot of these areas. All of these, PRP is really good. When you have tears, you can do fat. When you have talar joint OCDs and subtalar joint degeneration, that's where mesenchymal stem cells start coming into play. Bone marrow can be really effective. Fat can also be effective, but bone marrow is much more important. So this is just a picture. Achilles tendon, we talked a little about that. Percutaneous fasciotomies and tenotomies can be really effective, certainly within scars and fascial releases. Neuroma, I've used alcohol in the past, not anymore. Ultrasound is really good for assessing these and seeing where the nerve is. So here's the nerve. So you've got your little spermy. There's the sperm head, and there's the tail. That's your neuroma. So radiofrequency ablation used to be the way forward. I used to do that a fair bit, but there was certainly a high rate of pain as a result of it. And Mark would attest to this too. The radiofrequency for some is really effective, but at the end of it, you do have a cohort of patients who get uncomfortable numbness and persistent pain, but there's also a group of patients who get repeat neuroma formation. So RF ablation has given way to cryo. Cryoneurolysis has become the big new fella. So essentially what it is we're freezing nerves now. So we get what we call Wallerian degeneration. It's a much more regenerative method of dealing with things because we're not killing the nerve off, we're we're degenerating the axon, and therefore we're causing a persistent block. So with local anesthetics, you get a 6 to 12 hour block. With Botox, you get up to 3 months. With cryo, you get anywhere between 12 to 24 months of pain, or probably 12 months is much more likely. But it is a much more better way because the nerve regrows in there. So here's a nice little thing. So that's the myelin sheath that we're looking at. Thanks to Kalman here, he's given us the video for this, but basically the cryoablation probe goes adjacent to the nerve. It actually freezes that nerve, and the axon isn't resistant to freezing. It's the endoneurium, which maintains the ultrastructure of the nerve. And so you then get a block, either a sensory or a motor block. So the nerve signals are not going, but as time goes on, the axon starts growing back up. And that's how cryoneurolysis works, basically. So there are various things associated with cryoneurolysis. We use various types of different gases to get the right amount of freezing. We use different types of probes. We have to get the right environment in place. But it has a lot of applications in back pain, arthritis, neuropathy pain, cerebral palsy, multiple sclerosis, stroke, where you can use it in the spasticity sphere. And what are the complications? Well, dysesthesia is probably one of the things that is the most likely. It's transient. It can last anywhere up to 6 to 8 weeks. It's very, very rare to get neuritis and all these sort of things. Obviously, if you go from a mixed sensory and motor nerve, you can get a reversible motor block. But they're all reversible. The issue is how long the reversibility takes. Okay, unlike other things, it takes a bit longer. So I thought quickly I'll talk to you about 3 interesting cases. We've got our painful metatarsalgia, we've got our Morton's neuroma. We can see it there on ultrasound, and we do it via ultrasound-guided injections. So there's our RF probe, but cryoablation is as good. This is another case of Achilles tendinopathy. We had this area. We could see the Achilles tendon here, and then that same plantar, the plantaris tendon. And so we were able to release that up with tenotomy and hydrodissection. And then this is an interesting one. We had this case of a lady who was in her, was 26, has a presumed diagnosis of compartment syndrome, had mini fasciotomies. Ultrasound showed this structure coming out. And this is her in her relaxed and dorsiflex, so that's going up and down. You can see how the vessel is starting and stopping. So there it is again, and then that's her dorsiflexing and closing and then relaxing, and it's opened up again. So that's where ultrasound can be really helpful to identify where the pain generator is. And we've been ablating these actually. we've had 12 months worth of data now on 4 patients. Not a huge number. It's really hard to find these patients, but the ones who come through, they'll all complain of pain just here. It hurts here, doctor. And there's a vessel there. That's the site. You do a local anesthetic block. They have immediate improvement from that provocative testing of flexing and extending. If they get that, then you can put an RF probe into that area and just ablate that nerve. And within, 3 months, they're pain-free. And that, we've followed them up now for 12 months, and all of them have been pain-free. So quite effective in a lot of these sort of things. So cryoneurolysis, just wanted to show you a case. This guy was had been a AFL player, had a large, he'd had a medial gastrocnemius release by one of the foot and ankle surgeons around here, who pranged his sural nerve and had formed a neuroma. So this is what we saw on ultrasound, large fusiform neuroma. It was about 15 millimeters in size by 6 by 5 millimeters. He also had a reconstruction of his medial deltoid ligament with a tib post tendon transfer. And so he was stuck. He could not weight bear on that side, had severe neuropathic pain on the dorsum of his foot, but also couldn't really bend his foot because of the scar tissue that was there. So what we did cryoneurolysis to that. So we put a 13 millimeter probe into that. Immediate improvement within 2 weeks. He was completely improved of his neuropathic pain. And then what we did hydrodissection of that tib post tendon where the scar tissue was. And he's back to able to stand on tiptoes. He also had neuromas, which we've been dealing with for some time now, and that's slowly improving. So his quality of life has improved quite significantly. This is cryoablation, so we've got our neuroma, we do the same thing basically with RF. They have about 3 months worth of worsening symptoms, and then by about 8 weeks, their pain is reduced by 50%. By about 3 months, they're all pain-free. Back to running, back to being able to work. So this bloke had a large, hallux valgus deformity and quite a flat foot, and essentially what we do is put it in there and then ablate it under ultrasound. And this lady is a patient who had spasticity, so you've got the very typical adductor type appearance. This is her pre, and see how little movement she's got. See? And this is post-cryo. So spasticity can be really life-changing for a lot of people. And that's where a lot of this sort of stuff comes in. That's pretty much it, really.